Ma'am, you can start. You are in live now.
Okay, thank you.
Madam.
Okay.
Vasant sir, shall we go?
Yeah, you can.
Yeah, thank you, sir. So, a hearty welcome to our Academics with Institutions 2.0, the year 2025. This is the first episode we are starting this year. A hearty welcome to all of you. And as you all know, I'm the National Coordinator, Dr. Priya Shivali, welcoming you all for this first episode. I take this opportunity to extend my heartfelt gratitude to all of you for joining in for today's program. This collaborative initiative involving premier institutions has indeed set a benchmark in academic excellence, and we are sharing knowledge and innovation in these episodes. Thank you all. And thanks to our national president, respected Dr. Vasant Kalatkar sir, for continuing this for the year 2025 also. Hearty welcome to our president, Dr. Vasant Kalatkar sir. Hearty welcome to our president-elect, Dr. Neela Mohan ma'am, our immediate past president, Dr. G. Basavaraj sir, who had laid the foundation for this academics with institution. I welcome our HSG, Dr. Yogesh Parikh sir, and our National Treasurer, Dr. Atanu sir. Hearty welcome to our chief guest, Dr. Baldev Prajapati sir. Thank you so much for accepting and being on this first episode today. Welcome to our guest of honor, Dr. Professor Kamraj sir. Thank you so much and hearty welcome to you. And welcome our Vice President of South Zone, Dr. Preeti Galgali ma'am, our Chief Advisor, Dr. Jagdish Chinnappa sir, and the whole department of Madurai Medical College. Thank you so much for participating on our maiden episode today. I now request our respected HSG, Dr. Yogesh Parikh sir, for your official welcome address. Over to you, sir. Unmute, sir. Please unmute.
Good afternoon, all the respected seniors and dear colleagues. I welcome our ever-smiling President, Dr. Vasant Khaladkar ji, President-elect, Brain and Beauty both together, Dr. President-elect, Dr. Neelam Mohan Madam, and our beloved President, Dr. G. Basavaraj sir, and our today's chief guest, Dr. Baldev Prajapati sir, and guest of honor, Dr. C. Kamaraj sir, National Coordinator, Dr. Priya Madam, and our advisor, Dr. Jagdish Chinnappa sir, Dr. Preeti Galgali Madam, Dr. Nandish Bhai, Dr. Amal Raj, Dr. Jalil Ahmad, Dr. Nandini Kupuswamy Madam, and all the dignitaries on this. Dr. Amol Pawar is also here, Dr. Raj Kumar, and the whole department of Madurai Medical College. So, first of all, congratulations and thank you very much to our team 2024 led by Dr. Basavaraj. We completed the 15th episodes last year in the 2024, and this is the first episode of this year 2025. So we have celebrated, and now we continued the celebration again with academics and institutes. So thank you very much, Dr. Priya and Dr. Jagdish Chinnappa sir, for well coordinated and well appreciated by the across the country, all involving all the teaching faculties and the Department of Pediatrics everywhere. So we heartily welcome our chief guest and the guest of honor. Over to you, Priya Madam.
Thank you. Thank you so much, sir. I now request our respected President, Dr. Vasant Kalatkar, sir, for your message.
Yeah, I will start with the respected dignitaries, esteemed faculty, dear colleagues and friends. I bring greetings from Indian Academy of Pediatrics as a president CIP. It's really an absolute privilege to address this distinguished gathering of at academic with institution. That is the second episode, a visionary initiative that exemplifies the power of academic collaboration in pediatrics. You can see that what was the is a power, publicity, and famous all this that those episode. So really, I couldn't resist me to stop from academics. That's a academics with institute. It's really lovable. Whenever the whenever there is an institute, it touches our heart, where we learn, where we get nourished, and where we get the knowledge. That's really the great thing we get. And one should respect our institute, whether it's our primary school, whether it's our nursery school, and whether it's our college, PG, super specialty, whether it's a corporate hospital where we learn. And even you have to consider our own hospital as an institute, because we learn each and every day from our patient in our institute if you are in a private practice. So I always respect institute, and that's why I couldn't resist to stop this program. And thank you, Dr. Basavaraja, Dr. Yogesh Bhai, Dr. Basavaraja, our past president 2025, Dr. Yogesh Bhai, our current IAP secretary and last year secretary, Dr. Attanu, Dr. even Upendra Kinzavadekar. Really, I want to express my deepest gratitude to those who have worked tirelessly to build and sustain this platform. Dr. Neelam, I welcome you and on this platform, and I know in future also you are going to continue. What to tell about Dr. Jagdish Chinnappa, Dr. Priya Shivali, Dr. Amal Raj. So these are the great pillars. It is the concept I know by Dr. Jagdish Chinnappa, given to Priya, executed by Priya, and Dr. Amal Raj is going to add one more feather in this program. You have meticulously instrumented its platform where the nation comes to recognize the invaluable contribution of the institution in shaping the pediatric intellectual aptitude. Baldev Prajapati sir, really just on a one call, he said, Vasan bhai, academics के लिए क्या होना आप बताओ. Even that is the specialty sir का. Sir को 11th hour पे भी बोलो तो भी he is always ready. Thank you sir for accepting our invitation. And Dr. Preeti Galgali and my all the vice president, all zone, really thank you for your dedication to academic excellence and institutional synergy has left an indelible mark on the program. I want to extend my heartfelt appreciation to the organizing team and contributor who have brought together brilliant minds, thought leaders, and passionate educators to make this event a really. How can I forget the institute with president? Dr. Kamraj sir, really thank you. In spite of really, in spite of all your busy schedule, busy academics, you done this a great job. My special thanks to Dr. Chigarvilo also, who is the instrumental in making this. Dr. Professor Nandinar, Dr. Rajkumar, Professor S. Muragasam, Dr. Lakshman, and Ram, and all those students who are going to present. This really, this year, that's why we are thinking of, and we are going to have a Yuva Pedicon to give the chances to the student, these all young buddies. So this initiative is a testament to the fact that academic thrives when institutions come together, fostering an environment of learning, research, and professional elaboration. As we embark on this new year, my vision is to strengthen and expand this initiative, ensuring that more institutions, educators, and young professionals benefit from this academic exchange. Let's continue to build bridges between knowledge and practice, between institution and individual, and between experience and innovation. I look forward to a transformative 25, a year of growth, collaboration, and excellence in pediatric academia. Thank you once again. Jai Hind, Jai IAP.
Thank you. Thank you so much, sir, for your inspiring and encouraging words. As we all have agreed, we will have this academics with institution once a month, that is third Friday of every month. So today, as it is inaugural, we are having it on Thursday, but from next month onwards, sir has accepted to be it on third Friday of every month. So I now request our President-elect, Dr. Neelam Mohan ma'am, who had attended many of the episodes last year and given valuable suggestions. We would like to hear from you, ma'am. Over to you.
Thank you so much, Very good afternoon, respected Dr. Vasanji and Dr. Baswaraja, Dr. Yogeshji Atanu, and Preeti Galgali, our Vice President and past President Singarvelu. In addition, big respect and regards to Professor Kamaraj and Dr. Prajapati, who are our chief guest and guest of honor. And along with it, Jagdish, Priya, and Amul for having designed this program and taking it forward so beautifully. To other audience who have been attending this and the Madurai Medical College team, which includes Nandini, Rajkumar, Lakshman, and Raman. We look forward along with your PGs for this. All that I have to say is simple 2 lines. Education thrives when knowledge is exchanged. And this is what we did last year. And what I learned was that there was so much of wealth in the institutes, which when we heard about the institutes, it came as a surprise to me. There were so many things which I myself didn't know, that how these institutes were founded, and the learning probably was even a couple of people. It's the like Abdul Kalamji says, it's the thought, it's the dream with which you can change. And these institutes were created most often by dreams of some passionate pediatricians who worked hard towards it in a lot of centers that they did that. So with that, I will end up saying, together we learn, together we grow. Let's exchange knowledge, learn and grow. And we look forward to this monthly seminars as we move forward.
Thank you. Thank you so much, ma'am. Indeed, we found many gems of institutions from India last year. So we are exploring more this year too. Thank you so much. I now request our immediate past president, respected Dr. G. Basavaraj sir, who laid the foundation last year, wherein we had Golden Jubilee episodes. And thank you so much for all the support and encouragement. Request for your remarks, sir.
Yeah, thank you very much, Dr. Priya. So academics through the institution is one of the flagship program of Indian Academy of Pediatrics, where we could be able to explore a lot of things which is very relevant to the teachers, practicing pediatrician and postgraduate. So fortunate, our Honorable President of Indian Academy of Pediatrics, Dr. Vasant Kalatkarji, along with Dr. Neelam Mohan Madam, and of course, our dynamic Secretary General, Professor Yogesh Parik, Dr. Atanu Badra, Dr. Preeti Madam, and all who have been very, very instrumental taking this program to the another height. And the academicians like Professor Baldev Prajapati ji and Professor Kamraj sir, with the team of all the teaching faculties who has been here to take this academics through the institution to make it a very, very meaningful way. What really which is required for all our pediatricians, what Indian Academy of Pediatrics, which is really required to giving a very meaningful value to our members of Indian Academy of Pediatrics. This is one of the way where we can contribute immensely to the academic growth. And of course, our all executive board member and OB member, and of course, all the past office bearers like Professor Singarvelu and all who have been very, very contributed immensely in the last year also, and Satish Sharma ji were all there here. So they are always there to contribute immensely to this organization. And I'm sure this year, this academics through the institution will go to the greater heights under the great leadership of none other than Dr. Vasant Kalatkarji, who has been very, very instrumental in conducting all the academic activities in the year 2025 also, with the great effort from Dr. Priya Shivali, our national coordinator, and well guided by our chief advisor of our academics through the institution, Dr. Jagdish Chinnappa. So I am sure this will make a big wave with a lot of innovation in this year also, which will be very, very useful to all the members of academy. Best wishes for the program.
Thank you. Thank you so much, sir, for constant support and encouragement. I now request our National Treasurer, Dr. Atanu Badra, sir, for your remarks as you're traveling. we might lose you with when you go offline. So I would request you to speak.
Thank you, Dr. Priya. So this is the first of the 2.0 this year to kick off, and we are grateful to Dr. Chinappa sir and Dr. Priya to have accepted the request of our President, Dr. Vasan sir, to continue this year with certain modifications. And again, congratulations to Madurai Medical College for agreeing to be the starter for this year. So again, this was a program where we came to know about different institutions. This year, we are looking with interest again to know at least 12 more institutions which are there in the country and doing great work for the children of the country, and of course, an important role to play in IAP. So I think this is the first one, so that's why it was a extended inauguration. But hopefully, next time from next months, we will speak only one line. Thank you, Priya. Thank you.
Thank you. Thank you so much, sir, for joining in. I now request our HSG, respected Dr. Yogesh Parikh, sir, to introduce our Honorable Chief Guest, Dr. Baldev Prajapati, sir. Over to you, sir.
Yeah. So thank you again, Dr. Priya Madam. So we know Dr. Baldev Prajapati, sir. Sir doesn't require any formal introduction. We all know him as a great academician and a great leader and visionary thinker about this all. Baldev Prajapati sir served as a HOD and the professor in the GCS Medical College Hospital and Research Center in Ahmedabad. Sir is a MD Pediatric from the Bijay Medical College, having a gold medalist degree, and Prajapati sir served IAP, Central IAP, as an executive board member in 2002, 2003, 2005, 6, and 2011. Sir also served as a member of the ACVIP IAP Committee on the Immunization in 2009, 2010, and 2016 and 17. Sir served in the ID chapter as a chairperson in 2009, and several IAP modules he has contributed in the infectious disease, how do I manage EPID, then all about fever, AMS, NTP, REP module, and many more. Sir served as the president of IAP Gujarat State Branch in 2003, and then Sir was awarded FIAP by the Central IAP in 2005. Sir has so many awards in his head, and received the Alembic Traveling Fellowship in the IAP GSB in 1984. Sir delivered so many orations also, specifically Dr. Tapan Kumar Ghosh, ID chapter oration in April 2015, then Dr. A.V. Desai, Madam Oration, IIP Gujarat in 2016, Dr. Ashok Kapse oration in the SPECT, March 2022. And sir has written so many books also, Essential Procedure in the Pediatrics, IAP Clinical Examination Pediatrics, Signs and Symptoms in the Pediatrics, Ready Technover. And sir has more than 100 publications in articles in the medical journals, and 56 chapters in the books, and almost every academic program, sir, is there. Including this, our IIP Tuesday PG Clinic in Gujarat, our e-Gurukul program, and sir had participated in so many international and national conferences. So, and more, he delivered more than 2,000 academic talks across the country and internationally. So, sir, thank you very much for accepting our invitation as a chief guest and honoring Central IIP invitation. Thank you very much. Over to Dr. Priya, madam.
Request our respected chief guest, sir, to speak few words. Over to you, sir. Baldev, sir. So please unmute, sir.
Yeah, sorry. Good afternoon, friends. Thank you very much, Dr. Priya, and specifically Dr. Yogeshwar, for your kind words of the introduction. Our president, very dynamic and over-smiling person, Dr. Vasant Khalatkar, President-elect, Dr. Neelam Mohan Madam, immediate past President, Dr. G.V. Basavaraja sir, My friend, Dr. Jagdish Channappa, probably his brain was after this program during the last year, and all other office bearers, and I will say dignitaries on the screen. At the outset, let me express a word of gratitude to the office bearers and specifically the people involved in this program for inviting me and giving this opportunity. All of us know that we are fortunate that we are working as the developed platform. But if you look at the back, that our ancestors, when they started to work as a pediatrician, they didn't have even a single bed in the academic institutions. They created at least some corner, few beds, and from that probably the journey continued. And we are fortunate that working at this most developed, I would say, field in the pediatrics. And this is therefore I would admire this idea that always history is very important because it is inspiring all of us. And many times I'm sure that at this time, in the newer generation pediatricians may not be aware that what are the exact situation of the pediatrics few years back. I will say few years, just I will say 50, 60 or 70 years back. And if we know, we realize that how much our ancestors have contributed, how much they have struggled, how much they have contributed. And therefore, I will say we are fortunate to get this platform for working as a developed, I will say, pediatrics, and even with the super specialties. So certainly I will admire this type of the program that is academics with the institution, which was started last year under the able leadership of Dr. G. Basavaraja. And of course, with the, I will say, advice and everything which you concept by Dr. Jagdish, and I would say well implemented and executed by the whole team, particularly Dr. Priya and so many other friends associated with this. I will say that this is really important program. And it's good that even Dr. Vasant and his team even has consented to continue for this year also. And I would like to say the greetings to the Madurai Medical College that today this institution selected for this, I will say, mentioning the history of this medical college in the past. I have some good memories with the Madurai Medical College because I visited in 1984 when I was most junior person, a junior assistant professor. And my madam, my teacher, Dr. Mississippi Desai, sent me for the visit of some institutions. The first one was EGMO, Institute of Childhood, Chennai, during that time Madras. And I remember that Dr. Sundaravali madam was there, and she advised that better you visit even this Madurai Medical College. Because this institution with this nutrition rehabilitation center, probably you will not be able to see anywhere else. And to be very frank, when I visited this institution in 84, I know that the time has, like anything, spent, and already probably the institution has been developed even in a better shape. But during that time also, this development of, I would say, institution as a whole, and specifically the nutritional rehabilitation, was in the advanced stage. I'm sure that at present it must be the super advanced stage. And if we see that how it was started, even I remember that Institute of Childhood EGMOR was started by Dr. S.T. Achar sir. And I remember that he had one textbook of pediatrics by Dr. S.T. Achar. We used to read during our undergraduate days because there were hardly any Indian books. And I remember in his book also, there were the photographs of Madurai Medical College. I'm talking of around 80 or so. And I'm sure that with this bright history of such an institution, probably the institution which was the pioneer for the subject of pediatrics in this country, must have contributed a lot. And I'm sure that it will be quite interesting for all of us to know that how this institution has developed, what is the present, I will say, facility available, what particular specific, I will say, super specialties have been developed. And I'm sure that when the junior persons working at present, when they are discussing their, I will say, clinical material and presenting, it will be quite interesting for all of us. Once again, thank you very much, all the office bearers and even the program people involved, coordinator Dr. Priya and her team, for inviting me and giving this opportunity. Thank you. Thank you very much.
Thank you. Thank you so much, sir. It's a blessing to have you as our chief guest for our inaugural episode. Thank you for your inspiration and being a role model always to all the faculty and the postgraduates. As always, you attend and guide the postgraduates always. Thank you. Thank you so much, sir.
Thank you, sir. Baldev, sir. He is always ready for any academic moment. Thank you.
Thank you. Thank you, sir. I now request our Vice President of South Zone, Dr. Preeti Galgali, ma'am, for your remarks and to introduce our respected guest of honor, Professor Kamraj, sir. Over to you, ma'am.
Thank you so much, Dr. Priya. Good afternoon, everybody. The great academicians online and offline. It is a pleasure to be here with this truly academic program once again in this year. So I congratulate the past team and the new team, and I wish them the very best. But nothing gives me more joy today than listening to Prajapati sir and introducing the dawn of pediatrics in the country, Dr. C. Kamraj, MBBS, MD, FIAP. And you will be just astonished to know that sir did his MBBS when I was less than 1 year old. And I can see sir today standing and sitting so upright. It's indeed a moment of great pride and honor for me, sir. And I wish you lots of health and happiness. And to share in very, very brief his very, very long CV, I would say that he has been an absolute stalwart in Madurai Medical College. And he joined Madurai Medical College way back in 1968 as a tutor in biochemistry. He went on to do not only his DCH and MD from Madurai Medical College, but also a certificate in nutrition. And Dr. Baldev was talking about the NRC at Madurai Medical College. Yes, it was under his care that it flourished so well. Not only that, he was an executive board member of the CIAP twice, and he was the organizing chairperson of the 15th National Conference of the IAP. At the state level, he has been the IAP Tamil Nadu state chairperson. Not only that, he has also led the IAP Bulletin of Tamil Nadu state, and he has also been in the building committee. So you can see for yourself that his commitment to IAP is complete as an educationist, as an administrator, as an academician. And coming to what his teachers think of him, I think he is a teacher whose brilliance lit up the lives of thousands of students who themselves are in the audience today, and they are leading Madurai Medical College to greater heights. His students describe him as very lovable, as a great mentor who leads by example, full of discipline and extremely ethical. Thank you, sir, for blessing us with your presence and being the guest of honor for the opening program of Academics with Institution. We are indeed very, very blessed.
Thank you, Kamraj, sir. Really, I'm blessed. Like teachers like you, we are having a teachers like you. Thank you, sir. Priya.
Request you to speak few words, sir. Kamraj, sir, please unmute. If somebody,
Thank you.
Yes.
Vanakkam. Welcome to the temple city of Madurai for our first meet of the year 2025. Respected President, past President, President-elect, Honorary General Secretary, Chief Guest of the afternoon, our respected Director, Institute of Child Health and Research, Madurai Medical College, my colleagues, and all our friends in IAP. It's a pleasure and privilege to be here as a honor guest in the first meet itself, probably because of my age and my prolonged stay in the Department of Pediatrics. Has found a place for me here on this first meet in our Madurai Medical College Pediatric Department participates in this academic feat. With my over 50 years of experience in pediatrics, till the end of the 20th century, I will just recollect, we face different problems entirely, not what we face today in this 21st century. We had all the 10 killer diseases leading to high morbidity and mortality, and adding to the extraordinary strain on the caring pediatrician because we have very limited resources, fewer people, more number to care. We also had the other problem of severe malnutrition in 60 to 75% of the under 5 children, contributing to the increased morbidity and mortality, leave alone the vaccine-preventable diseases. But fortunately, things have taken a different turn with the advent of newer antibiotics, better child infrastructure, and improved socioeconomic status, and government and private sector extending excellent pediatric care throughout. But unfortunately, what we face today is little unfortunate from my point of view, because we have to care for lesser number of rare diseases with needing greater resources, all our skills, and with variable outcome. In nowadays, a case of severe dehydration will become all right with the 4 pints of IV fluids, some ORS, and some advice. Within 48 hours, they go home happily and live happily ever thereafter. But I'm not quite sure whether we have the same outcome with our NIU graduates and all others who are here with us, taking all our efforts and with variable outcome. That's the most unfortunate thing. I hope we will concentrate more in preventable aspects of disease, starting with adolescents, antenatal care, intranatal care, early breastfeeding, timely immunization, and the most important thing, education of parents, which we are, I think, not to the fullest possible extent, we are successful. And we also have the problem of antibiotic abuse, multi-drug resistance, leading to adverse drug effects. It's an important cause of morbidity and mortality presently. Added to that, we also have the problem of malnutrition again, but different type. This is due to affluence and improved socioeconomic status and availability of and more liberty to our children, obesity. We have an NRC here presently in our institute. I was asking our director, what is the role for NRC at this place? Now, of course, the problem is entirely preventable, unlike before. With proper nutrition advice, follow-up, and parental education. We also have the problem of drug abuse, behavioral disorder. This is also partly due to lack of our proper follow-up of our children with parental education, and institutions also participating, both the schools and colleges. So I wish the present-day pediatricians great success in this challenging environment to produce very healthy adults with optimal potential, full potential developed to full development and growth, and contributing to the national development and making India a real superpower. Wish you all good luck and best success to you. Thank you.
Thank you, sir. Your blessings will definitely work for future. Thank you, sir.
Thank you so much, sir. Because of your efforts, and I must thank Dr. Singaravelu, sir, for bringing the Madurai Medical College as a participant for today's session. Thanks to you. Thank you so much for your blessings, sir. I now request Dr. Amal Raj, our EB member from Tamil Nadu, to introduce our chairperson, Professor Nandini Kuppusamy, ma'am. Over to you, Doctor.
प्लास्टिक फोल्डर मागितलं ते खाली ठेवलं.
Good afternoon, respected dignitaries. Good afternoon, everyone. I'm deeply honored in welcoming our Chief Professor Nandini Kuppusamy, Madam. As we all know, the city of Madurai, in Tamil we call it as Tunga Nagaram, which means the city that doesn't sleep. Similar to that, Professor Nandini, Madam, also has done enormous work for the upliftment of IAP, the pediatric fraternity, and the pediatric community in the district of Madurai and southern Tamil Nadu. She has been a pioneer in the development of the pediatric fraternity from the south, and she has got an enormous student base. She has worked hard a lot, and I'm deeply honored in welcoming her. And as we all know, Professor Nandini Kuppusamy, ma'am, is currently the director of the Institute of Child Health and Research Institute here in Madurai Medical College. And she is also the president of the IAP Madurai branch. And she has been very active president here. She has been, in fact, our Tamil Nadu group is very active, and Madam has been in the forefront in putting a lot of activities from Madurai. I'm deeply honored in welcoming you, ma'am, and I hereby hand over the proceedings to Madam. Thank you.
Thank you, Nandini, Madam, for being a chairperson. And I know under your all able leadership, we will be having a successful UA Pedicon at Tamil Nadu, at Kanyakumari. Thank you. Welcome.
Thank you, sir. Ma'am, I think with the blessings of Goddess Madurai Meenakshi Amma, we will start today's session. Over to you.
Madam, unmute, please. Unmute. Nandini, Madam, unmute करिए.
Unmute, ma'am.
Thank you.
அனைவருக்கும் வணக்கம். My first blessing is to be associated with my guru, my mentor, my philosopher. That is my first blessing. I thank God for putting me beside him. I appreciate the IAP for envisaging such a wonderful program, and we have joined the journey of iconic institutions right from the start of 2025, inaugurating this year's program. I have to put in an important word. This flagship program of education has helped us to bring out the salient features of our institution, which is a 75-year-old institution. And for this, I first of all thank Dr. Singaravelu, sir, who was very much insistent, persistent in making us to take part in this. Sir?
Extended service.
Thank you very much, Singaravelu, sir. And Amalraj, sir, you have been saying such wonderful words for us and our institutions. And thank you so much, sir. Can I start with the slides, madam?
Please start.
Yeah. I would like to share these slides. Just a moment, it's online. My undergraduate student is doing that. Are the slides available?
Yes, ma'am. It's perfect. You can continue.
It starts with our IAP Rosebud. Yeah. So please sit down. Yeah. This is the logo of our Madurai Medical College. It was established in 1954. This is where we are. And we have about 38 districts in Tamil Nadu. And you can see the India picture. We are way down. And this building was established in 1954, complete stone building. And this was brought into effect by our Chief Minister, Mr. K. Kamaraj. I think all Kamarajas will be like that, I think, who is a visionary. This is the first government medical college built outside of Chennai after independence, which also celebrated its platinum jubilee. So this is Mr. K. Kamaraj, our Chief Minister, the one in the middle, with the dhoti. This was inaugurated by our Honorable Minister for Health, Mrs. Rajkumari Amrit Kaur, in the month of August in 1954. And MCA gave its recognition to Madurai Medical College in 1961. And the first batch of 50 medical students graduated in 1960. The first dean took charge in 1963. So this is the Gothic austere appearance of the stone building, even in 1957. This Madurai Medical College has got a total number of 250 MBBS seats, 182 PG seats, and 47 super specialty seats, and 17 pediatric MD seats, with 1 DM neonatology seat. We have asked for 4 DM neonatology seats. This is the breakup. This medical college is associated with hospital, which is called as Government Rajaji Hospital. It was first called as Government Erskine Hospital, Madurai, and it was opened on 1940, 18th November. It was renamed as Government Rajaji Hospital in the centenary year of our CM of Madras State, Mr. Chakravarti Rajagopalacharya, who also happens to be the last governor of India. That there was a post like this. So Government Rajaji Hospital, the bed strength was 4420 with daily census OP of 7,000 and an inpatient of 3,000. The important additions to this 75-year-old building has been given by JICA, Japan's International Cooperation. This is first of its kind in Asia, the JICA building. This is the latest addition to GRH with a whopping 315 crores invested. You can see our health minister, our MP, our dean, and our director of medical education in the photo. This was opened by our own chief minister, Mr. Muka Stalin, on February 26th of last year. This has all interventional theaters. The cardiothoracic, cardiology, vascular have hybrid theaters. That is, you can do minimal invasive surgery also. With ENT general surgery plastic, with prefabricated walls, laminar floors, and that is why it's called modular theaters. This is a look into this. The next feature will be a super specialty building of 150 crores. Neurology, neurosurgery, MGE, SGE. A very special mention about TAI, which is Tamil Nadu Accident Emergency Care Initiative, because it has created the emergency department, which we used to call as casualty. No more we call it casualty. And there are 6 pillars in that. And the last pillar is pediatric resuscitative emergency, called as PREEM. So this TAI initiative has revolutionized the concept of emergency medical care in Tamil Nadu, because NHM thought that the sustainable developmental goals to reduce road traffic accident by 2020 by half. So what was casualty became TAI, and emergency department in 2020, and it gave a facelift to all the emergency departments. So NMC has since made emergency department mandatory for starting of new medical colleges in the country. So at present, we have about 110 TI in 41 DME institutions. So as you can see, the last pillar will be pediatrics under TI. This is the logo of PRAME, and instead of casualty, we call it as PRAME now. The core concept being a low-cost, innovative strategy for saving young lives in the golden hours of critical illness with zero delay. So we have 6 resuscitative trolleys with 1 warmer in this PRAME unit. This is the CMOG building, Comprehensive Emergency Obstetric and Neonatal Care, to helping to reduce the MMR and IMR of about 60 crores. We have about 15,000 deliveries in this building. And we have about 5,500 admissions, neonatal admissions per year. Coming on to the Institute of Pediatrics, which was started in 7777. A very nice number to remember. This is our institute where we are right now. We have 6 units functioning, 5 professors, 2 associates, 14 assistant professors, and 5 senior residents. As you can see, the 3 doyens of pediatrics. Sir was mentioning about S.T. Achar sir, who has written a book for pediatricians, and Dr. K.A. Krishnamurthy sir, whose centenary we celebrated under Dr. C. Kamaraj sir's leadership, which went on excellently well, and he was instrumental in starting the Department of Pediatrics. And of course, J. Viswanathan sir, who is a great teacher for us, and his centenary comes in 2027. And he was supposed to be authoring our S.T. Achar sir's book, editing. So it started in 1958. We took up DCH in 1964, and MD Pediatrics came in by 1967. So right now we have 17 MD Pediatrics per year uptake. Under the National Health Mission, Government of India, these are the places in our institute. Of course, our OPD with specialty clinics, a separate hemato-oncology ward. Next to Chennai, we are the biggest one who is running it in Tamil Nadu. PICU, which is now called as HHDU, High Dependency Hybrid Unit. PRAME, Pediatric Resuscitative Emergency. ICHH, otherwise called as daycare, for thalassemia, for hemophiliacs and hemoglobinopathies, and pediatric surgery, our twin. So on Tuesday, we have gastroenterology and endocrines, Wednesday, neurology, Thursday, cardiology, Saturday, nephro, hematology, and asthma clinics. Our yearly statistics of our OPD is about 90,000, nearing a lakh. 1/10 get admitted per year, 10,000 to 12,000. PICU admission is 1/10 of our admissions, that is 1,000 to 1,500. Now, this is our PICU or HHDU, which was started in 14/4/2022. It costs about 2.5 crores with state-of-the-art facility. We treat about 100 to 150 cases per month. And we cater to about 10 districts surrounding Madurai, which feed us. Coming on to daycare, now it's called Integrated Center for Hemophilia and Hemoglobinopathy. This is the hemophilia cases, totaling about 23. in and around Madurai. The main object of the program of ICHH is prophylaxis, no more treatment. So that is the way we concentrate, the NHM concentrates. So this is for hemophilia treatment. This is what the government is spending, especially for FIBA. You know, one vial costs 30,000. The resurrection of NRC, we are not very happy. It was Dr. C. Kamaraj sir who gave it a very grand burial. So this is our kitchen with a nutritionist and a cook. We have catered from 2019 with nearly 500 to 600 beneficiaries per year. Coming on to DEIC, District Early Intervention Center, the hub for all these 4Ds, as you all know: birth defects, deficiencies, delays, and disabilities. This is our center of 1 crore. Each district in Tamil Nadu has got a plinth area of 1,500 square feet to cater to all these children for early intervention. So we have, from 2016, this was inaugurated. Until last year, we have seen about 1 lakh children. And the physiotherapist has catered to 41,000. We gave calipers and POPs. The audiologist has seen 35,000 with 200 cochlear implants. Each implant goes to about 7 lakhs. Our optometrist has seen about 50,000 cases, 45,000, with 30 cataracts being done. This is the look into our DIC. And last but not the least, the surgical department, pediatric surgery. You can see the numbers have increased. It has gone up to 2,500 in 2022. We also have a scheme called as Chief Minister's Comprehensive Health Insurance Scheme, from where we have to buy our consumables and mend our infrastructures. A very important mention of hemato-oncology. During the period of our chief guest, Professor C. Kamaraj sir, a separate hemato-oncology ward was started to treat children with leukemia. Our institute is the second hospital in Tamil Nadu where children with cancer are treated in an exclusive way. You can see the statistics. We have about 200 cases, ALL topping. This is our hemato-oncology ward. So I right now thank the CIAP presidents of 24, Dr. Basavaraja sir, the secretary Yogesh Parikh sir, treasurer Atanu Batra sir, and of 25, the president Dr. Vasant Kalakar sir, and president Dr. Neelam Mohan, who says education thrives when knowledge is exchanged. And we also thank the Tamil Nadu IAP president, the past president, Dr. Balashankar sir, Thirumurugan Serane sir, and Dakshayani madam, and the 25 president, Dr. Rajendran sir, Narmada madam, and Dr. Rajkumar, who is in my team. I'm very privileged, and I really thank God because I happen to be the president of IAP District 2025 with Dr. Sendil and Dr. Prasanna, the treasurer. Thank you very much.
Thank you, Nandini madam, for the elaborative Madurai Medical College history and all the statistics. I am very much fortunate to visit the Madurai Medical College before 3 years, where the Dr. Balashankar was the head of department. And I have a wonderful lunch with all the staff members. So I still remember that. Thank you.
Can continue with the next speaker, Dr. Rajkumar sir.
Yes, ma'am. So first of all, My pranam to all the seniors, my teachers, and all the Central IAP office bearers and organizers of this event for giving me this opportunity. I'm Dr. Rajkumar. So let me share the screen now. So is it visible, my screen? Can I go ahead?
Yes, sir. Please continue.
Okay, ma'am. Thank you. So I'm Professor Rajkumar, and I'm the treasurer of IAP TNSC for this year also. So what I'm going to talk in the next 10 minutes, I'm not going to bore you with all the theory or other details. I'm going to talk about our true experience, the ICHRC, that is Institute of Child Health and Research Centers experience with dengue. Traced with dengue. That's the name I've given. Like, dengue doesn't need an introduction. We all know it's a rapidly spreading arboviral infection in the tropical and subtropical regions all over the world. Almost 250 crores, there is 1/3 of population of this year, they are at risk of developing dengue, and 5 to 10 crore infections are happening every year. It's a miracle that the deaths are very less because of the human activities of pediatricians all over the world, right? And these two lines represent the tropics, the Tropic of Capricorn and the Tropic of Cancer. The countries in between are called tropical countries, we all know. But because of global warming, now dengue slowly spreads into subtropical countries. So how is it our old, this dengue was there in India before? It was not so. It was introduced in around 1940s when the Second World War happened. There was mass movement of troops between all over the world. It happened. So probably this dengue virus, which was native to South America and Africa, it was introduced in India by the around that time when that war was happening in India near Burma. So the first case of dengue, the case was isolated in Calcutta in 1945. After that, what happened? It spread like wildfire. We had extensive epidemics of dengue in India since 1963. And during the first epidemic in national capital of 1996, it rose into national prominence. We all know, I was a school student, college student at the time. We came to know about dengue only during that time, 1996, when it happened in Delhi. You must be knowing that all those things. Then after that, it was reported from all over the India, from except Kashmir, from that place to Kanyakumari and Gujarat to Calcutta, all the places they experienced dengue epidemic. And by 2010, what happened? Singhi et al. He conducted a multi-center prospective observational study across 34 ICUs across India. So what he found out? Dengue was the most common tropical infection, reason for admission in the ICU, followed by strep typhus and AES and malaria. So what was our relationship? That is Tamil Nadu. We all know that whatever affected, the first any problem come to India, it affects North India, and you people suffer for some time. Then ultimately it reaches us, any invasion or infection, whatever. So ultimately dengue, it came to us. The first cases, it was like mentioned in early 60s, but the documented cases outbreak happened in 2001 when I was a postgraduate student in Institute of Child Health, Chennai. We had a lot of cases, only 800 reported, but the number must be more than 10%, 10 times of this number. A lot of deaths happened. We didn't know the pathogenesis. We didn't know the management. It was like, blind man treating something, explaining something like, the situation was like that. And 2 more dengue outbreaks happened. And this time, the South Tamil Nadu. Ma'am already put a picture and showing Madurai, all those things. So in 2012, we had a severe, very great epidemic. A lot of, the morbidity, mortality was very high. And it also happened in Tirunelveli, which is 70 kilometers away from this Kanyakumari. That is the extreme tip of India. In 2014, in Rajapalayam, in 16 in Palani, and again in 17, and again in 20, 21, 23. Even COVID epidemic couldn't do anything to dengue. Dengue, it coexisted along with COVID, and it killed a lot of our children. So I'll put a slide showing our period, last 8 years numbers I have taken, and out of 100 fever cases each year, we had minimum 10 to 15% of cases came as positive. So this slide shows that. So out of 100 cases of fever, if you admit, the chance of getting dengue positive would be around 16%. That is our situation. So what I'm going to talk, how we reduce the morbidity and mortality over these 10 years, and what were the pitfalls in understanding the pathogenesis, making the diagnosis and treatment of dengue fever by our private practitioners, our primary care physicians, and our postgraduates. So what is the pitfall in pathogens? This antibody-mediated enhancement. This is a major pitfall. Our people couldn't understand this problem. What is this antibody-mediated enhancement? When we explain in simple words, it's really tough to explain this to those people. So what is this? I'll explain. It's nothing but, heterotypic antibodies are non-protective. That is, antibody produced against one single serotype, that is only protective. The another, if second infection, it is going to relate to this antibody-mediated enhancement. I put some picture. So main thing is this E protein. The E protein on dengue virus, that is the one which is most antigenic. If antibody is produced against this E antigen, that is homologous infection, and this antibody comes, when it goes and neutralizes the E antigen, that virus is gone, finished. That virus now cannot go and replicate. It will be dealt by our reticular endothelial system. So what happens in secondary infection? When another infection happens, now the antibodies they are not binding with this E antigen. This E antigen has a different epitope in each the shape in each and every serotype. So what happens now? This E protein, E antigen remains alive, ticking, and it now gains entry into the mononuclear cell. So instead of dying, now it is entering into the mononuclear cell. Now it multiplies. Now two things happen, double whammy. It is going to multiply enormously and pumping billions and billions of copies of virus. And this virus goes and infects everywhere around the body, producing a microangiopathy. It infects the endothelium of each and every organ, the capillaries in every organ. And our body tries to overcome this by producing a tsunami of cytokines. The pro-inflammatory cytokines, they come. So this increased viral load and this tsunami of cytokines, that's the one which is going to result in dengue hemorrhagic fever and dengue shock syndrome. This is new to us. 20 years back, all these things we didn't know. So what happened? There are factors from enhancing this ADE. These things we come to know only, last 4 or 5 years only, and maybe last 5, 6, 7, 8 years. The steroids, if it is given in the first few days of infection. So what happened, these parents used to sit on the pediatricians or the primary care physicians for fever. We all know dengue produces that very severe fever, which is not going to come down and touches the baseline. So what happens? Our people, previously they used to give for this any ordinary infection, they give steroid, the infection comes down and they go. But in dengue, what happens if steroids are given for fever in the first few days of infection? That child is going to develop a severe ADE and a severe DHF and DSS. It's like we tell the primary care physician, if you write steroid for any child who is having fever, you are literally writing a death warrant for the child. So this is the way. This is one of the advice we gave it to the private practitioners and primary care physicians. And epidemiologically, what happens if dengue viral 1 infection follows dengue viral 2, that is going to be a severe DHF and DSS. And the dengue virus 4, it's a notorious one, a virulent strain. Unfortunately, it's there. It's present in our Madurai. This is a virulent infection can produce a severe ADE and a DHF and DSS. And one more thing, there were initially some rumors, but now there is established evidence that other flavivirus infection, because we have maybe 10s and 20s of flavivirus infection already established in India. So this flaviviral infection, these children had previously, or even they say JE vaccination and prior JE infection, if it is there, these children will develop a severe DHF and DSS because these viral infections, they also produce antibodies. These antibodies are going to produce this ADE, antibody-dependent enhancement. So once we understood these things, we advise the primary care physician regarding this, and we reduce the morbidity and mortality by doing this. So what are the pitfalls in the diagnosis? So these 3 pitfalls we found out during the initial days. What happened, whenever a child comes with fever, what our primary care physicians do, They do CBC on the first day of fever or on second day of fever, and they find absolutely normal CBC and tell the parents, your child is safe. Nothing. There is no chance of your child having dengue. These parents, they go home. They do not take care of the child after that because they were told by the doctor. They literally trust us. So they were told that there is no dengue. So ultimately, when the child becomes very sick on the 6th day, they'll be brought to our hospital. So this one we noticed. The second one is using the dengue card test. This dengue card test, it produces a lot of false positive, false negative. I'll tell you in the next slide. And third one, recently ordering dengue IgM ELISA on day 1 or day 2 of fever. No, we'll see. So we all know CBC, first 72 hours, it is going to be absolutely normal. Only by 72 hours, there would be leukopenia. Still, the platelet count would be absolutely fine. And there would be borderline, 1.5, 1.4, the count would be there. And by 4th day only, the platelet count is going to fall. By this time, the leukopenia would be there. By 5th day, the leukopenia would be severe. Still, the platelet count would be around 70, 80,000. And 6th day, when the leukopenia improves, now only the platelet is going to come down. So by looking at the CBC, we can easily identify on which day of fever and which day of illness the child is having. So this one, we taught to our primary care physicians, our postgraduates, and our private practitioners. So by looking at CBC, you can understand whether the child is having a serious problem. Because what we taught them, that leukopenia, if it is very severe on 4th day, that gives an indirect clue that the child is going to have a severe DHF or DSS. Because if the lymphocyte count is less than 1,000, especially if it goes even below 500, definitely you can reserve a bed in ICU for the child. That is the thing. No, it is like severe lymphopenia is a indirect association with the DHF and DSS, increased chances. So by looking at, by interpreting the CBC and doing CBC at the correct time, we have prevented a lot of morbidity and mortality. What about dengue card test? These tests are doing right and left during those initial times. Two things it has done to us. One, this dengue card test has a lot of false positive. So all these children were told that your parents were told your child has dengue. They come and occupied our fever ward. Fever ward was full, and a child who is really having a dengue, that child couldn't get admission inside our ward because of this problem, the high false positive. And one more thing is, the most dangerous thing is the false negative. This test also have that false negative thing. When a child who is having dengue is told your child doesn't have dengue because card test is negative, that could actually literally a death sentence again. So we told the private practitioners, please don't do dengue card test. They are condemned. Never do that. So what to do? What test to confirm? How to confirm them? So we told them that IAP is recommending only this dengue NS1 antigen by ELISA. The ELISA is the catchword, keyword. It's not NS1 by card. ELISA between day 1 to day 6 of fever. After day 5, we do IgM ELISA. But after day 5, it would be useless. So best thing is doing dengue NS1 antigen by ELISA between 1 to 6. So by telling the private practitioners, and now they are doing all these things, we have reduced the morbidity and mortality. And these investigations are also important because sometimes we will be, like tunnel vision, we will be looking at only CBC and NS1. Sometimes when a child is admitted in our fever ward, we tell our postgraduates, look at the blood gas. When the child is sick, when it is admitted in ICU, blood gas will tell you whether the child is having a shock, whether the child is intractable shock or not. And looking at the hematocrit every day and electrolyte, especially the hypocalcemia, is found in almost all cases of DHF and DSS. Calcium, it's asymptomatic usually, but we can give calcium supplement because hypocalcemia and next one is hypoglycemia. These two actually worsen the outcome in DHF and DSS. So these two investigations are not to be overlooked. So what are the pitfalls in management we have found out? We all know that dengue produces a dramatic fever. The fever goes to 41, 42, 43. It goes to any degree. It doesn't come and touches the baseline. It remains. The parents will be literally on our head for this treatment of fever. So what happens? Our private practices, because of this pressure, they started using NSAIDs, aspirin, ibuprofen, mefenamic acid, diclofenac. What happened? All these children who received this combination of drug, paracetamol and brufen or mefenamic acid, they had a severe DHF or DSS. Whether they are intrinsically prone or not, ultimately what happened? They had developed a severe internal bleed and died. And those children who received steroids, they are double whammy. They developed a severe internal bleed as well as a severe dengue because of ADE. So our latest our advice to the private practitioners is give only do debit sponging, and paracetamol is our number one drug. Number two is paracetamol. Number three drug is paracetamol. So don't go beyond paracetamol for fever management. Don't worry about fever. If the parents are very much particular about fever, admit the child, and you just observe the child and give paracetamol 6 hourly and do debit sponging. That is the most common prudent thing to do. No need to go for NSAIDs or steroids or any heroic measures are needed. So this management actually has reduced the morbidity and mortality by almost half. So when the child goes into critical phase, DHF and DSS, what are the pitfalls we noticed? These children, previously what we noticed, these children were actually misdiagnosed. Actually, the child was having compensated shock, but the children were referred here as child was positive with CARD test or CBC was showing thrombocytopenia, and they were not referred in an ambulance or anything because the child was not at all touched. The child was in shock, in compensated shock, but they were walking inside our emergency room. They come with a lucid conscious level and ultimately collapsing in half an hour. So that is the thing. So how we managed, we told the private practitioners and primary care physicians, you touch the child. You, without touching the child, you just don't put the step and look at the investigation and diagnose dengue. You touch child. This is the famous this one, the touch, the 5 touch, the CCTV, we call it as the color, capillary refill time, temperature of extremities. Look at the pulse volume and pulse rate. So this is the most important one. BP, if you are able to take blood pressure, okay, well and good. But the CCTV will tell you whether the child is having compensated shock or not, and give fluid bolus in your institution or in your hospital, resuscitate and refer to us, because without resuscitation, without touching, if you are referring, the child is going to die, because if shock is allowed, child is going to die. And this is the second one. Anticipate bleeding. Because by the time you look at the CBC, this is for our postgraduates in ICU, you look at the CBC and see the sudden drop in hematocrit. By the time is already gone, the child is gone into shock, and the child had a severe bleed, and child it is going to die. So what to do? Instead, you anticipate bleed, a severe internal bleed in a child who is having profound and refractory shock, or who is having persistent metabolic acidosis or multi-organ failure, which is not amenable to our treatment. And those children who received NSAIDs, go into the history and find if they were given NSAID and steroids, you better anticipate bleed. Even if the child has slight abdominal pain and there is a mild drop in hematocrit, you know that child is probably bleeding inside. And pre-existing peptic ulcer disease, oral anticoagulant therapy, these children definitely will bleed. So by anticipating the bleeding, by making the blood available at any time, we actually prevented some deaths and morbidity. What about the fluid, the additional management? Because as I already told, the investigations, hypoglycemia, hyponatremia, metabolic acidosis, and hypocalcemia, they were actually ignored by our postgraduates. And later on, we insisted that hypoglycemia, hyponatremia, hypocalcemia, when they are there, actually they are associated with additional morbidity and mortality. So these are to be corrected. The metabolic acidosis, if you see, if it is uncorrectable, if it is continuing, that's a sign of hypovolemia, shock. This due to lactic acidosis from tissue hypoxia. That child needs more fluid. So adequate fluid replacement is the most important key here in metabolic acidosis. Don't give soda paper. Okay, what is the role of steroids in DSS and DHF? Because some secondary level hospitals and some private practitioners, they were giving steroids, prevents morbidity and mortality, but not so. A Cochrane database of systematic review in 2017, what is it telling? Steroids have no effect on severe bleeding, severe thrombocytopenia, duration of hospitalization, on decreasing mortality, the need for blood transfusion, and development of complications such as shock. So steroids are not at all useful for the first 2-3 days for fever, for control of fever, and they are not useful even at the end, extreme. When the child has DHF and DSS, it's not going to be useful. What about platelet transfusion? Initially, during the first in the 2010, our clinicians, the tendency was to chase the platelets. They used to give platelet transfusion by 50,000. then it reduced to 40, 30. It was like in movie, they reduced the price. Similarly, they were doing that. This behavior actually was reinforced by the attenders. We call as dengue panic syndrome. The family used to cry a lot when the platelet count reaches 70, 60, 50, 40. We give, like a commentary, like every 12 hours we give. And what happened was unnecessarily these children who received platelet, two things it cost. It cost actually. One is the cost of treatment was going up. Second was the danger to child's life. So we explained to the private practitioners that what is happening in dengue was this. Normally, any damage to endothelium results in release of ultra-large von Willebrand factor. This is going to bind with platelet and it's going to cause microthrombi and microangiopathy. Under normal circumstances, what happens? This endothelial damage also releases ADAMTS13, is a cleaving protease. This ADAMTS13 is going to destroy this ultra-large von Willebrand factor. So this prevents the development of microangiopathy. This is, if any already viral infection. But dengue, it causes release of ultra-large von Willebrand factor as well as deficiency of what happens if you give platelet for 30,000, 40,000, you are going to worsen the problem. Now, microangiopathy will happen without any hindering, and you are doing more harm than good. So this thing we told to our practitioners. So as IAP guidelines, we taken the platelet count of less than 10,000 for giving a platelet transfusion. And if the child shows any external or hidden hemorrhage with or without thrombocytopenia, we give packed cells, and we avoid packed cells. We give better fresh blood because it contains additional amounts of ADAMTS13. What about stopping the fluid therapy? Initially, during the early course of dengue illness in the 2012, maybe 13, 14, we lost a few children on the recovery phase. Because what happens, we started IV fluids, but we forgot to stop the IV fluid. So the child was given IV fluid continually, 3 ml, 2 ml, 1 ml per kg per hour. It was being forced into the system, while whatever fluid has gone into the third space, now it is coming back into the system, and that is going to cause a fatal pulmonary hemorrhage, pulmonary edema, pulmonary hemorrhage, and the child is going to die. So we lost a few children because of this. So we drummed up our postgraduates at the first sign of cessation of plasma leakage, which is indicated by a stable blood pressure, a pulse rate which shows a bradycardia, and peripheral perfusion, warm periphery and bounding pulse, and hematocrit shows a slight decrease, and urine output is improving and resolving bowel and abdominal symptoms. At the first sign of this, you stop the fluid, don't give fluids. Okay, so with this, we might have prevented some more deaths and morbidity. So what is the Madurai study? We actually because we had a lot of epidemics in and around Madurai. In 2017, there was some study done by the Department of Molecular Biology attached to the ICMR Vector Control Research Center in Madurai. The blood was sent from our department actually, the children were admitted, and along with the Department of Biotechnology, Madurai College, and Institute of Clinical Anatomy and Cell Analysis, University of Tübingen, Germany. So what was their finding? They found out all 4 serotypes are in circulation in Madurai, but that's the bad news. The dengue virus 4 is the dominant serotype here. That's why we had that much severe epidemics, DHF, more number of DHF, DSS we had. And what is the peculiarity of this dengue virus 4 is even in primary dengue viral infection, DHF and DSS can happen. And these children might be probably given GE vaccination or previously infected with other arbovirus. And dengue virus 4 also, the number of DHF and DSS increases even with secondary infection. This is because the possibility of viral proteins alone triggering DHF and DSS. Okay, so we come to the end of my story. Does the story end here? No. Dengue is here to stay, but we stand ready. Today, we know everything about dengue pathogenesis, diagnosis, and management. Here, I would like to thank the IAP for imparting us knowledge regarding all this. We had countless CMAs regarding dengue. We had all our knowledge because of the efforts of IAP. And so we now know everything about dengue far better than we did a decade ago. With this knowledge, we are fully equipped to tackle any epidemic which will come in the future. And I promise we will fight relentlessly to save every child affected by dengue. Thank you very much. Thank you.
Thank you, Dr. Rajkumar. Thank you. Really, it's a wonderful presentation. Really, what is the need of hours, need of time. Priya, let's go ahead.
Sir, yes, sir. Nandini ma'am, or Rajkumar sir, next speaker.
So good afternoon. I am Dr. Muriya Lakshmanan, Associate Professor of Pediatrics at Madurai. I am here to brief about research activities which have already been done at Madurai and what are the things which are going on now currently. True to its name, am I audible? So true to its name.
Please continue, sir.
So our Institute of Child Health and Research Center has been in the forefront of research activities ever since its established by the great Professor Dr. K.A.K. In fact, Professor Dr. K.A.K. himself had a very keen mind for research, and in fact, he had a publication in Lancet as early as 1976. He co-authored an article, Nutritional Rehabilitation Center for Children with Xerophthalmia. He co-authored that article along with Dr. Vedantam. He was the founder of Aravind Eye Hospital at Madurai. So here, as early as 1976 itself, he had publication. So ICHRC also collaborated with various national agencies for money multicentric studies. In 1998, an AIMS Incline Pulse Polio program evaluation was done, and Madurai was one of the centers for the study. And again in 2001, vitamin A and iron folic acid supplementation study was done, and Madurai was part of the multicentric study. And recently in 2018 to 20, we had a multicentric study done by ICMR and rotavirus impact assessment study and intersusception surveillance. And Madurai was one of the sentinel centers for the study. And our students have regularly bagged awards at various national state conferences for paper presentation, research paper presentation. In 2009, Bangalore Pedicon, a postgraduate, won the prestigious James Platt Award for Social Pediatrics. Again, even in this year, State Pedicon Tirunelveli, a postgraduate, bagged the V. Balagopal Raju Award for the best paper. Now, with the establishment of the multidisciplinary research unit at medical colleges by ICMR, the research has got a real boost. We already completed 4 studies in a department in collaboration with ICMR, and 2 more studies are ongoing and currently in collaboration with the Model Rural Health Research Unit. Again, one more unit of the ICMR. 1 more study is in the pipeline on improving the nutritional status of children with severe and moderate acute malnutrition. The project will start once we get the formal approval of the ICMR this month. And now I call upon a postgraduate, Dr. Karthivan, to briefly present 2 studies which are done and completed with the ICMR collaboration at Madurai. Karthivan.
Good afternoon to everyone. I would now like to talk about 2 research activities which has been carried out by faculties at Institute of Child Health and Research Center. The first one is on the correlation between serum magnesium and vitamin D levels and symptom control in asthmatic children in South Tamil Nadu population, which is a cohort study. It was conducted by our senior assistant professor, Dr. A.N. Karthik sir. So first, why was the study carried out? First, there was some relation between serum magnesium level and asthma. Magnesium antagonized intracellular calcium, which thus resulted in an inhibitory action on smooth muscle contraction, mast cell degranulation, and acetylcholine release. All these effects led to bronchial smooth muscle relaxation. Vitamin D, which acted as an immunomodulator, suppressed pro-inflammatory cytokine interleukin 17 and interleukin 13 levels, and it promoted anti-inflammatory cytokines like interleukin 12, thus helped in the pathogenesis of asthma. So the objective of the study was to assess the correlation between serum magnesium and vitamin D levels and symptom control in childhood asthma. It was carried out in Institute of Child Health and Research Center at Government Rajaji Hospital, Madurai. Children with asthma with age between 4 to 12 years attending asthma clinic at ICHRC were in the study population, and the study was conducted between October 2019 and August 2021. A total of 100 participants participated in the study, and it was a hospital-based observatory cohort study. The inclusion criteria meant the definition of asthma, which must have the following criteria. That is history of having wheeze and experiencing shortness of breath during or without any concurrent respiratory infection, estimation of peak expiratory flow rate, and reversibility following bronchodilata therapy, patients who are on controller therapy, that is inhalation steroid with a long-acting beta-2 agonist. those children with wheezing associated with other disorders like congenital heart disease, and those conditions which affected serum magnesium levels such as coexisting renal, endocrine, skeletal conditions, and malnutrition were excluded from the study. So a total of 148 children were found to be eligible as per the inclusion criteria, out of which 48 participants were excluded. One due to acute flare-up, due to poor compliance, diarrhea, and diuretics. So at the end, there were 100 participants who remained after exclusion. A total of 41 children were well controlled. A total of 31 children were partly controlled, and 28 children were uncontrolled. So these are the descriptive values of serum magnesium across the three groups of asthma based on symptom control. As you can see in the linear comparative graph, those with well-controlled asthma tend to have a very high serum magnesium level when compared to those with uncontrolled asthma who are found to have a very low serum magnesium level. A positive correlation study using scatter plots was done, and R value was found to be 0.78, which was found to have a strong positive correlation. So when we compared serum vitamin D3 levels across the three groups of asthma, it was found that there was no significant correlation association between the serum vitamin D3 levels and the different groups, the uncontrolled and well-controlled and the partially controlled group. On scatter plot, the correlation coefficient was found to be 0.017, and hence there was found to be no significant correlation between serum vitamin D3 levels and the asthma pattern. So from the study, my inference was serum magnesium level had a direct correlation with the level of symptom control in asthma, while serum vitamin D levels did not have any correlation with the levels of symptom control in asthma. Maintaining normal serum magnesium levels by regular consumption of magnesium-rich diet could help in achieving a better control of asthma. Whether there is a role for regular measurement of serum magnesium as a marker for asthma control will need a further validation. Though there are some recommendations from the study, there is a need to conduct a case control comparative study of magnesium and vitamin D3 levels of asthmatic children, both in the stable state and also in the flare-up in our setup, so as to determine if the magnesium levels are much lower during the acute flare-up state. A study to determine the degree of relationship between serum and intracellular magnesium levels is actually required. A randomized double-blind placebo-controlled trial of magnesium supplementation on children with asthma is to be done so as to assess its impact on the asthma control. I gone to the second study, which was done by a senior assistant professor, Dr. R. Venkatramanan sir. It was on urinary vitamin D binding protein as a marker to differentiate steroid-resistant nephrotic syndrome from steroid-sensitive nephrotic syndrome in South Tamil Nadu population. So the background of the study was because due to the damage in the glomeruli seen in nephrotic syndrome, the large proteins, which included vitamin D binding protein, were leaked into the urine, resulting in elevated urinary vitamin D binding protein levels. Since vitamin D binding protein is responsible for transporting vitamin D in the bloodstream, its significant loss in urine resulted in vitamin D deficiency in nephrotic syndrome patients. Some research suggests that urinary vitamin D binding protein levels could potentially be used as a biomarker to monitor the severity of nephrotic syndrome and assess the treatment response. The objective was to assess whether urinary vitamin D binding protein can be used as a marker for steroid-resistant nephrotic syndrome in Indian setup. It was carried out in Institute of Child Health and Research Center, Government Rajaji Hospital, Madurai. Children between 2 to 12 years, either a known case of nephrotic syndrome or a new case of nephrotic syndrome, who attended nephrology clinic in Government Rajaji Hospital, Madurai, were included as the study population. The study was conducted between October 2019 to September 2021. A total of 97 individuals, where 50 cases and 47 controls were included in the study. It was a case control study. All children diagnosed with nephrotic syndrome, either first episode or relapse of steroid-dependent nephrotic syndrome or steroid-resistant nephrotic syndrome, were included in the study. Those excluded from the study were congenital nephrotic syndrome and children with severe acute malnutrition. So total of 68 children were found to be eligible as per the inclusion criteria, out of which 18 children were excluded in view of severe acute malnutrition and congenital nephrotic syndrome. So at the end of the exclusion, there were 50 participants and appropriate 47 controls were included for further study analysis. These are the clinical characteristic profile of the participants as cases in our study. So on comparing the children with nephrotic syndrome and those without nephrotic syndrome, there was a significant correlation between urinary vitamin D protein excretion. A higher level was seen in those with nephrotic syndrome when compared to control, and was found to be statistically significant. Also, on comparing those with control and steroid sensitive and steroid dependent nephrotic syndrome, a statistically significant correlation was found to be between urinary vitamin D binding protein and the type of nephrotic syndrome, with steroid dependent nephrotic syndrome having a steroid resistant nephrotic syndrome having a higher mean urinary vitamin D binding protein levels. On a scatter plot, we found that steroid-resistant nephrotic syndrome patients were found the urinary vitamin D binding protein can be used as both a sensitive and a specific test for as a potential biomarker for diagnosis of steroid-resistant nephrotic syndrome. So urinary vitamin D binding protein levels were significantly higher in children with nephrotic syndrome than in the control children. Urinary vitamin D binding protein levels were significantly higher in children with steroid resistant than in children with steroid sensitive nephrotic syndrome. Urinary vitamin D binding protein had a good diagnostic validity in identifying those with steroid resistant nephrotic syndrome. At a cutoff of 936 nanogram per ml, it has a sensitivity of 100% and specificity of 56%. This cutoff can be used when urinary vitamin D binding protein is used as a screening test along with other parameters. A renal biopsy of children diagnosed with steroid-resistant nephrotic syndrome would have helped in relating the urinary vitamin D binding protein levels with different pathological lesions. Also, a large multi-center prospective study determining the urinary vitamin D binding protein levels at the baseline before the treatment and following up on the urinary vitamin D binding protein levels with illness progression could have helped in bettering the study. I'd like to thank everyone for giving me a chance. Thank you.
Ma'am, you can continue.
Sir. Dr. Ramsubramanian sir can continue the case presentation.
He is a dynamic personality heading our unit, Professor. Dr. Ramsubramanian, I think you can go on. Take the podium.
Thank you, ma'am. Good afternoon. Good afternoon, all. At the outset, I'd like to thank IAP and our director, ma'am, for giving us this opportunity. As Madam pointed out, we have a state-of-art pediatric intensive care unit in our hospital. And we being in the South Madurai, being a 75-year-old institution, we are not only a referral center for primary and secondary level hospitals, but also we do get cases from the nearby medical colleges, from private hospitals, private corporate settings. So we have the clinical material, we get this from nearly around from the entire South Tamil Nadu, we get the clinical cases. So we are going to present here one case which got treated in our intensive care unit with a condition which is thought to be rare is now becoming more and more common, and got completely recovered after managing in our institution. So we have with us today Dr. Mainuddin, who is our postgraduate, who will be presenting about the case and will be discussing on the condition also. Over to Dr. Mainuddin.
Good afternoon, everyone. I am Dr. Mainuddin, final year postgraduate from ICH RC Madurai. To make it spicy, we have kept the title as Brain on Fire, and at the end of the session, we'll be rescuing the brain. So we had a patient, a 11-year-old male child, first born out of non-consanguineous marriage, who is a developmentally normal child, brought to the casualty with the complaints of altered sensorium for the past 4 days, involuntary movements for the past 4 days. So the child was apparently normal 2 weeks back, following which the mother had noticed that the child had some cognitive problems in the form of difficulty in doing his homework. 2 days later, the child had convulsions in the form of vacant stare. The child was taken to the nearby hospital for the above said complaints, treated with some oral anti-epileptic drugs, and was sent home. Later, the child developed sleep disturbances and had some behavioral disturbances, like the child was aggressive and irritable and not obeying simple oral commands. Then the child had another episode of convulsion 1 week later while going to school in the form of tonic-clonic movements of the all 4 limbs. So he was taken to a nearby hospital where he was managed conservatively with anti-epileptic drugs and was referred to our hospital in view of persistent altered sensorium and persistent involuntary movements. So history, he didn't have no history of fever, no history of neck pain or stiffness, no history of headache or photophobia, no history of blurring of vision or vomiting, no history of stiffness of limbs or any abnormal posture. He had no sensory disturbances and no history suggestive of involvement of cranial nerves. No history of any trauma, no history of any exanthem, no history of loose stools, no history of any drug intake, no history of jaundice or any bleeding manifestations, no history of any malar rash or joint swelling, no history of loss of weight or no history of sweating or flushing of skin, no history of bowel and bladder disturbances. Past history not significant. Birth history all were normal. Immunization, child was immunized up to age, was developmentally normal. Studying, scholastic performance is good, studying 6th standard. No significant illness among family members. So on detailed clinical examination, child was pain responsive, lying in lying posture with the NG tube in position. He was afebrile, hydration was fair, no pallor, no icteric, no icterus, no cyanosis, no clubbing, no generalized lymphadenopathy, and no pedal edema. We noticed that he had pill rolling movements in his right hand. He was so aggressive and he was having the pill rolling movements. So on recording his vitals, his heart rate was around 160 per minute, regular in rhythm, normal volume, no specific character, no radio-radial delay, no radiofemoral delay. All peripheral pulses were equally felt. So he was having tachycardia. His respiratory rate was around 30, which was regular. His blood pressure recorded in all 4 limbs were high, more than 90th percentile. He was having hypertension. Capillary refilling time was less than 2 seconds. Central pulses, peripheral pulses were felt good. Temperature was around 99.2 degree Fahrenheit. So on detailed clinical examinations involving systemic examination, CNS examination, higher mental function, speech was having inappropriate words, memory and intelligence could not be tested, handedness was right-handed. Cranial nerves, there was no history, in examination, all cranial nerves were found to be normal. Spinomotor system, the bulk was equal on both sides, no obvious wasting. Tone was normal on both the limbs. The best observed power was around 3/5 in all the upper limb and lower limb. Reflexes were plus in all upper limb and lower limb. Superficial reflex, conjunctival reflex was present, abdominal reflex was present, bilateral plantar was around withdrawal. Sensory system, he was responding to deep painful stimuli. Cerebellum could not be examined. Gait could not be tested. Spine and cranium was normal, no meningeal signs. Fundus was normal. So other system examinations were also be found to be normal. So summary, a 11-year-old male child, the firstborn out of non-consanguineous marriage, who is a developmentally normal child, presented to us with a history of behavioral and sleep disturbances and history of recurrent seizures. On examination, the child was pain responsive and he was having autonomic disturbances like tachycardia, hypertension, and he was having persistent involuntary movements associated with altered sensorium. So we had a differential diagnosis of acute encephalopathy under evaluation to rule out acute sinus infection, autoimmune encephalitis, and seizure disorder. So we did all the basic blood investigations, which was found to be normal. MRI was done, MRI was found to be normal. EEG was done, EEG was normal. So we went with CSF analysis. So here CSF analysis, protein was 29 milligram per deciliter, sugar was 190 milligram per deciliter, capillary blood glucose level was normal. Cells were polymorphs 1, lymphocytes 1 per high power field. CSF culture had no growth. CSF JE was negative. CSF gram staining, no pustules or organisms. AFB stain was no AFB seen. CSF HSV1 and 2 RT-PCR was also negative. So we proceeded with autoimmune panel and it came to be NMDA positive. So even before the results came, we suspected autoimmune encephalitis and we started the child on injection methylprednisolone 30 milligram per kg per day and was given for 5 days, followed by injection IV intravenous immunoglobulin 2 gram per kg given over 5 days, 400 milligram per kg per day. So other supporting measures including antibiotics, antivirals, antihypertensives, and antibiotics were given accordingly. So now the child is on regular follow-up and was advised to take oral prednisolone 1 mg per kg per day for 6 to 12 months and antihypertensive medications. So on subsequent visits, child's BP was controlled and hence the antihypertensives were gradually tapered and then stopped eventually. Since the child developed the Cushing-Hyde features, you can see in this photo, steroids were gradually tapered and he is currently now on steroid sparing agent mycophenolate mofetil. So the child who came to us in a bedridden condition is now walking well and he is doing his daily day-to-day activities well and he is able to study well. So a few points about autoimmune encephalitis. It's a group of inflammatory disorders of the brain which have an autoimmune pathogenic basis. It can occur at any age with widely variable spectrum of clinical presentation, that is polysymptomatic. Early diagnosis and treatment leads to better neurocognitive outcomes like our patient Sheikh Haris. Causes, in most of the cases, there are no causes. In some cases, identifiable triggers like tumors like teratoma, infections, post-infectious viral encephalitis, blood-brain barrier disruption. So when to suspect an autoimmune encephalitis? So it is an acute onset of CNS symptoms associated with psychosis, choreoathetoid movements, recurrent seizures, cognitive impairment, autonomic instability, relapse after treatment after viral encephalitis. These are the following neural autoantibodies. So now we are going to see in detail about NMDAR receptor, which was found in 2007. So it was first described in 2007. Anti-NMDAR encephalitis accounts for 4% of all the encephalitis. Most common cause of seropositive autoimmune encephalitis in children. 40% of the cases are below 18 years of age. There's a few points about NMDA receptor. So clinical features, it is a prodrome lasting weeks to months, neurological, psychiatric, and autonomic dysfunctions. In 80% of cases, they will be having seizures. Movement disorders such as orofacial dyskinesias, choreoathetosis, balismus, opisthotonus, tremors will be there. Behavioral changes like temper tantrums, irritability, hyperactivity. And in case of advanced disease, the child will be brought up to us in stupor, coma, agitation with catatonia, and autonomic dysfunction. So investigation of choice to look for anti-NMDA receptor antibodies. In CSF, it is 100% sensitive and it correlates with severity. In blood, it is almost 85% sensitive. Other investigations in MRI brains, 65% of the patients will have normal MRI. 35% will have abnormal MRI with the non-specific cortical or subcortical changes in the T2 or FLAIR images. CSF findings will be lymphocytic pleocytosis, elevated protein levels, CSF-specific oligoclonal bands, and elevated CSF IgG index. Electroencephalography, most EEG will be non-specific finding like focal or diffuse slowing with epileptiform discharges. A typical pattern called extreme delta brush pattern is usually seen in 30% of anti-NMDR encephalitis. So there's another entity, seronegative autoimmune encephalitis. Only 44% of the patients with autoimmune encephalitis will have an antibody positive status. The definition of probable autoimmune encephalitis includes the rapid progression of symptoms and the exclusion of other causes, absence of antibodies in the serum and CSF, and at least presence of 2 MRI abnormalities indicative of autoimmune encephalitis, CSF pleocytosis, CSF specific oligoclonal bands, or elevated CSF IgG index, or brain biopsy showing inflammatory infiltrates. So the mainstay of treatment is immunotherapy. The first line therapy is intravenous methylprednisolone 30 mg per kg given for 5 days, intravenous immunoglobulin 400 mg per kg per day for 5 days, and we can consider plasma exchange 5 to 7 exchanges of 50 ml per kg every alternative day. On considering maintenance therapy, oral steroids prednisolone 1 to 2 mg per kg, monthly pulse steroids can be considered, monthly IVIG doses can also be considered. Currently, our patient is on maintenance therapy for 6 to 12 months with oral prednisolone. So having developed Cushingoid features, he is now on mycophenolate mofetil. Other steroid-sparing agents like azothioprine and methotrexate can also be considered. Second line therapy is 1 to 2 weeks from the completion of first line treatment acutely. Rituximab can also be considered anti-CD20 antibody, 375 mg per meter square weekly for 4 weeks. Cyclophosphamide can also be considered IV infusions of 500 to 1000 mg per meter square monthly for 6 to 9 months. Third line agents like tocilizumab and bortezomib may also be considered. So the take-home message is autoimmune encephalitis is more common than any individual viral encephalitis. So anti-NMDR encephalitis is the most common form. Etiology in children is most commonly post-infectious. Suspected in children with polysymptomatic presentation like seizures, movement disorders, behavioral issues, and autonomic disturbances. Our child had all of these features, so it is almost a typical prototype case. Still, a significant proportion of cases can also be seronegative. Immunosuppressive therapy is the mainstay of treatment. Early diagnosis and treatment gives better neurocognitive outcome. So this is our child in the left side of photograph. He is doing well and he has performed good in sports activities and have got prize. So the bedridden child who came in a pathetic situation is now doing well, and we are so very grateful, and it's so heartwarming to see him doing well. I thank my director. The brain has been successfully rescued. I'm very thankful to my director and my professors and my chief for this opportunity. Thank you all.
Thank you, Dr. Mainuddin, for that clear presentation. So, as Dr. Moinuddin said, this autoimmune encephalitis is now becoming more and more common than any other individual viral encephalitis. And the challenge here is they present with a wide range of clinical features. And the presentation is different in children from adults. Both have different types of presentations. So, in a child who is presenting with symptoms involving multiple domains, like a child presenting with seizures with cognitive impairment, a child presenting with seizures with cognitive impairment with some movement disorder, a child presenting with a neurological manifestation and a psychiatric manifestation, a child presenting with seizures with behavioral disturbance with some movement disorder. So like that, if multiple domains are involved, we'll have to suspect autoimmune encephalitis. That is a polysymptomatic presentation. That is what the main feature of autoimmune encephalitis in children. So any child presenting with polysymptomatic presentation will have to suspect autoimmune encephalitis. And why it is important is the diagnosis is mainly clinical, because many of the investigations, even our MRI or CSF, can be normal in majority of the occasions. Even after finding out so many antibodies, still we have got 60% of seronegative cases because of autoimmune encephalitis, and MRI findings again can be present only in 2/3 of the cases. 1/3 of the cases MRI can be totally normal. This boy had normal MRI, and even if CSF is done, the access to antibody studies is not that common. All the institutions may not have access to CSF antibody studies. This child, we had CSF antibody done at NIMANS. So by the time we got the results, it took 2 to 3 weeks for us to get the results, and by the time the boy had recovered completely. So even based on the clinical features, even before we could get the results, we started with the immunosuppressive therapy. And the initial injection methylprednisolone we started, but the boy's response was not that good. So we went ahead with the IVIG based on just clinical grounds. And as you see here, how the boy has recovered. So this, what we want to stress is, this encephalitis, unlike majority of the viral encephalitis, is a treatable encephalitis. Because the viral encephalitis, barring say the herpes simplex, majority of the viral encephalitis, they don't have any specific treatment. But here, they say for autoimmune encephalitis, we have got a specific treatment, and it's a treatable encephalitis. And identifying and treating the autoimmune encephalitis early can give we can give 100% results. As you saw in this boy, he has completely recovered, and his scholastic performance is back on track with all his achievements. We are happy to rescue this boy, and we thank our director and our administration for supporting us in treating this boy. Thank you.
So one question regarding the same case. What could be the reason
Yes,
for
ma'am.
hypertension in autoimmune encephalitis?
They can have autonomic instability, madam. Autonomic instability is also, the boy has got tachycardia and hypertension. So autonomic instability is also a feature of autoimmune encephalitis.
Any questions from the attendees here? Yes, sir, Jalil.
Wonderful presentation, sir. This autoimmune encephalitis, nowadays we always include investigation of choice as anti-NMDR antibodies, sir.
Yes, sir.
And this
Yes, sir.
boy needs periodic surveillance for the existence of malignancy, especially the teratoma.
Yes, sir. Initially, this disease was found to be a paraneoplastic syndrome. Initially, it was identified as a paraneoplastic syndrome. But in children, the most common cause is not neoplasm, but it is mostly following some infection. So in children, the most common cause is post-infectious than neoplasm. But as you are telling, he has to be monitored for any underlying malignancy. If any clinical features arise, we will do it, sir. Thank you, sir.
Yes, MSV, sir.
Nice work, Madurai team. Nice to see the great work being done there. I just want to ask, when you send this panel for the auto antibodies? Did you set a panel, or how do you do that in your institute?
It was panels. They have got a panel in demands, so we just sent the panel, sir.
And how long takes to get the report?
For us, it took 2 to 3 weeks to get the results.
Thank you.
Because it's a government setup, but we do get early from the private.
Yes. Private setting, you can get in 1 or 2 days. But the cost is, it's cost around some 18 to 20,000 in private setting, I hope.
I'm pretty sure you'll be starting
for biofire.
while awaiting the report. I'm pretty sure. Thank you.
Wonderful presentation, Ram Subramanian sir. Ram Subramanian, it was a wonderful.
Thank you, sir. Thank you, sir.
Can I just put in a word, madam? Just a moment. The topic in Nelson, autoimmune encephalitis, has been authored by one Dr. Joseph Dalmo. He was the one who was instrumental for this throughout the world, and he has been cited in many articles. So he is a neurologist specializing in neuro-oncology, paraneoplastic syndromes, and autoimmune encephalitis. So right from the horse's nose, we have been, Nelson has took him as an important person to write this topic on autoimmune encephalitis. We are getting many cases, and I appreciate Dr. Ramasubramanian and his team members who have been able to rescue this child, this boy.
Baldev sir.
Baldev Prajapati sir. Yes, sir. Your inputs.
I think just 2 points I have to mention. Very rightly, I think mentioned nowadays autoimmune encephalitis is very common. We do come across. But in the pediatric practice, as Dr. Ramesh mentioned, it is post-infectious is the most common rather than the neoplastic. And that too, suppose I have seen at least 2 cases that you have diagnosed herpes simplex encephalitis, even CSF PCR positive, patient recovered with the full course of the acyclovir for 3 weeks, and the patient may come back after some time with some manifestations. And during that time, we have the confusion. It is really the relapse because it is also known in the herpes simplex encephalitis. And many a times, it may be the NMDR encephalitis following the herpes simplex. So I think whenever we come across these type of story, better to keep in mind. And very rightly, here probably we could diagnose herpes simplex in the past, but otherwise any non-diagnosed, even non-identified viral encephalitis can also later on come as the autoimmune encephalitis. So I think nowadays somehow, whether we are wiser to detect it or really the incidence has increased, we are not sure. We are learning from our pediatric neurologist friends, but certainly we do come across, I will say, compared to so rare, I would say frequently in the practice. So it's very certain, very important point to keep in mind. And I think very rightly somebody said that the hypertension in these conditions is with the autoimmune disorder, instability, very common. There may be the flushing of face, tachycardia, hypertension, and this hypertension is transient. Once you treat the condition, it disappears. So I think this is also very common. And third point, I think for the investigations, better to avoid the biofire. Nowadays, people say that by doing the biofire, probably spending so much amount of the money, you may get the multiple viruses. And then it becomes a confusion to you. So if they say that, suppose if you have some clinical, and that's why, that's the, I would say, beauty of the clinical medicine. If you have suppose strong clinical background, that it seems to be herpes simplex or Epstein-Barr virus or varicella or something, better to go for the PCR for that virus, specific. That becomes, I will say, more important, more even the useful and more specific also. So naturally, if you are not aware, we are not sure, patient is critical, in that situation, probably we may take the liberty and may go for biofire. But as far as possible, go for a clinical conclusion and go for the investigations accordingly. It's very specific PCR for that virus, and that may be, I would say, quite rewarding. Thank you very much. Thank you very much, madam.
Thank you. Thank you so much, sir, for your valuable input. Dr. Jagdish Chinappa, sir. I think so.
Yeah. Thank you, Priya. Thank you, Priya, for asking me to speak. I think wonderful presentations from Madurai. Especially, we had a very super the outline of the institution itself at the outset. And I'm sure Dr. Pramod Jog is also there today. So he's also going to give us a summary of what happened today. I'll only be brief in saying that a lot of very important clinical pointers were mentioned, especially regarding to dengue and nephrotic syndrome. And just as a rejoinder to Dr. Baldev Prajapati, we have seen quite a few cases of NMDA-related or autoimmune encephalitis syndromes, and presentations can be very, very, very different. And what is really remarkable about this case is the subacute onset of this disease. If you look at this child was smoldering along for a couple of weeks before he got admitted to the hospital, being diagnosed with various kind of different disorders. And usually that's what happens in NMDA, that you don't really pick it up at first unless it is hyperacute. It just goes on smoldering along with some headache, some altered sensorium, sometimes vomiting only. And we have had, and unless you really pick up the abnormalities in the central nervous system, you might miss the diagnosis for quite some time. And I think it's important that we also realize that imaging may be of no use, EEG may be of no use, in contrast to the viral encephalitis, where all this will give you characteristic abnormalities in both the EEG and the MRI. So I think we are on to a very subtle disease, a subacute disease, and things that need to be picked up with a very good clinical acumen. Congratulate the Madurai team for a wonderful management of these cases.
Thank you. Thank you so much, sir. There's one more question. Can we start immunosuppressive drugs keeping anti-NMDR antibodies report? I don't know. Immunosuppressive drugs.
Can you start, madam?
I think before the report comes, maybe Dr. Lakshman is here. If you can.
Yes, ma'am.
Yeah,
This case we started even before the reports.
Before getting the report.
This case we started on immunosuppressive. We didn't wait for the results because waiting for the results may damage the brain. So this case we started immunosuppressive therapy even before we got the results. Just based on the clinical.
Yes, thank you. Request Professor Kamraj, sir, your final comments on the presentations from Madurai Medical College.
Oh, it's excellent. It's thought-provoking. For me, it is all news to me because, as I told you in the beginning, we deal with different problems, and present-day pediatric is more interesting and challenging. I congratulate your youngsters.
Thank you, sir. I welcome our past president, Dr. Pramod Jog, sir. Very well known for presenting the Jogisms on every episode of Academics with Institutions last year. We all are waiting for your remarks, sir. Over to you.
Thank you. It was and Madurai has been a very pet city. Madurai is known as the Athens of the East. It's known as Athens. Athens, as you know, is the capital of Greece because it has a rich cultural and historical heritage. And I had the fortune of giving the oration in the name of K.A. Krishnamurti long back, known as Kak. Okay, so that was in 2007. And when Dr. Kamraj was there as the president. And today with Dr. Baldev Prajapati as the chief guest and Dr. Kamraj, actually I call him, his spelling is K-A-M-A-R-A-Z, but I call him C-A-L-M-R-A-Z. He's a Kamraj. He's a very cool and quiet person. So he's Kamraj, okay? And with Dr. Nandini Kuppuswamy as the chairperson, who elaborated entirely everything about this Madurai Medical College got established in 1954. And the government college, the second one in Tamil Nadu, that means the first one outside Chennai, and associated with this government Rajaji Hospital. And I, of course, remember always those short forms. So one of them I remember is that TAI. So that was that Tamil Nadu Accident and Emergency, initiative. And the other one was, of course, PREM. PREM is very nice. That's a pediatric resuscitation emergency care. I'm glad that she paid her, homage to Dr. S.T. Achar, Dr. K. Krishnamurti, the founder of ICH in 1958, and Dr. J. Vishwanathan. They have been the phenomenal and important people in this particular area. And then Dr. Raj Kumar gave many inputs about the pitfalls in relation to the management of dengue and the experience at this Institute of Child Health, and particularly related to that antibody dependent enhancement, how steroids can worsen this particular problem. And giving steroids, I would remember his sentence that giving steroids in the first few days of dengue is like writing a death warrant for the child. Okay, I think I am listening this sentence for the first time, but we must remember that this experience, the Madurai experience of dengue type 4 virus, which is associated with DHF and DSS, and also prior JE vaccination. So these are some of the factors which he elaborated related to the antibody dependent enhancement. And of course, the diagnostic pitfalls which he told that not to have this CBC done on day one, and doing that card test. That card test is something which is had lot many false negatives, and that's why it should not be done. And NS1 should be done in the initial few days, which all we do, and IgM ELISA after day 5. See, dengue virus is a very disciplined virus. It will be there for 11 days and then it will disappear. So just try to observe as to how this virus is behaving in the body. And some pitfalls in relation to the fever management, not to give those NSAIDs like aspirin and ibuprofen and mefenamic acid, which are likely to increase that chance of GI bleeding, and giving only paracetamol, and of course no steroids. And then I remember that 5-in-1 maneuver, the magic touch that he said, he has given lot many short forms to me today. So that CCTVR, when you use your hands for the color and the capillary fill time and the temperature and the pulse volume and the pulse rate, that's a very good thing to diagnose shock at the early stage. He also mentioned about the importance of glucose and the hyponatremia and the metabolic acidosis, and the importance of adequate fluid management as the key in the management. And of course, he told that, many physicians, particularly adult physicians, with due regards to all of them, they are in the habit of using steroids. And once I asked my senior physician, I said, why are you using steroids in the management? And exactly all the points that he said, he was, saying that it, has all the impact on bleeding and thrombocytopenia and all. But we must remember that steroids don't have any impact on bleeding, thrombocytopenia, hospitalization, need of blood transfusion and complications and so on. But people continue to use that, and that's very important. People many a times have thrombocytophobia, in addition to cytopenia, they have a phobia, thrombocytophobia, that the platelet count is going down, so they are worried. Okay, and they continue to chase the platelets, and he nicely labeled it as the dengue panic syndrome, right? And he also told something about ultra large von Willebrand factor, which I did not, of course, completely understand, but I will talk to him sometime. And of course, he told us to follow the IAP guidelines in relation to platelet transfusion when the count goes below 10,000. And during recovery, he has also warned us to be aware of the fluid overload. He told us about that Madurai study, and I'm sure Rajkumar will never sleep, as Madurai is known as what he said, Tunga Nagaram, isn't it? So proving that Madurai, when I went in 2007, everyone told me, I went there in the midnight, and all the city was moving. The trucks were moving, the cars were moving. It was fully crowded. Then I asked somebody, how is it? He said, the city never sleeps. So the name that he told today in Tamil probably is Tunga Nagaram. Okay, so I'm sure Rajkumar also will never sleep, and he will prove that Madurai is really a Tunga Nagaram in the management of dengue. And then our friend, Murugesa Lakshmanan, he told about the research activity starting from K.A. Krishnamurthy. He studied on the Nutrition Rehabilitation Center of 1974, and then Dr. Karthipan, he told about the Karthik study on the magnesium level, how it has a direct correlation with the symptom control in asthma, and vitamin D, which doesn't have a correlation with the symptom control in asthma. And then Dr. Venkataramanan's study related to the elevated urinary vitamin D binding protein level, it would be useful as a marker for steroid-resistant nephrotic syndrome in addition to the other markers. Okay, and the last prototype case of autoimmune encephalitis. It was a great presentation with all the details, and I'm sure all the postgraduates who probably attended the program should present it in exactly the same way. And Dr. Moinuddin did an excellent job under the guidance of Professor Rama Subramaniam. And he also told about the anti-NMDA receptor encephalitis. So it was a very excellent academic feast today. I remember, as I told you, in 2008, Dr. Kamraj, with his friends, I think Venkateshwaran and others, he had organized a state level pedicon in Madurai. And of course, when I reached in the midnight, I was wondering as to who will feed me. But then I went to a place called Ashoka Bhuvan, somewhere near the medical college. And I remember to have those mush idlis and golden dosas and idiyappam, even at midnight, Of course, in the next 3 days, my wife never forgot to purchase the cotton saris. They are very famous in Madurai with that batik print. Okay, so if at all you happen to go to Madurai, and Kamraj knows the exact places in the market where you get them. Anyway, so I pray Meenakshi Amman blesses the institute for all the progress of this institute in the future. Thank you.
Thank you. Thank you so much, sir. You emphasized the right points mentioned by all the speakers, and for your crisp jogisms. I think we all are fortunate to have your jogisms after each session. I request our HSD, Dr. Yogesh Parekh, sir, before we close, any comments from your side?
Yeah. Thank you, Department of Pediatrics, Madurai Medical College and Rajaji Hospital, for the excellent presentation throughout the session. And we learned so many things, mainly focus on the dengue. We are seeing the dengue cases everywhere in the country, and you mentioned except the Kashmir. So maybe that is the coolest place, but here we are in the Surat and the Gujarat, Mumbai, everywhere we are facing so many challenges in the dengue, and we learned something new also. So thank you very much for giving the something new sites for the dengue, and thank you, Nandini Madam, for wonderful cooperation and support to the central IIP and the whole department. And always our jogis of Pramod jokes, sir, commentary. We are learning something new, sir, from you every time, each session. So thank you.
Thank you, sir. I think Dr. Rajkumar sir's talk on dengue, it was like the IMNCO guideline, IMNCI guidelines for the general practitioners, non-pediatricians also seeing children. I think for them it is very easy to follow the CCTVR and the no steroids. I think that was a very useful one, sir. Thank you so much. I think if we have the dengue vaccine, which are already in the pipeline, studies are going on for Dengvaxia and Qdenga, I think we will be relieved with some cases of dengue at least. I now request our coordinator, Dr. Amalraj sir, to deliver the vote of thanks.
Yes, good evening, friends. I'm happy to propose the vote of thanks as coordinator for the first episode of Academics with Institutions. I thank our vibrant president, Dr. Vasant Kaladkar sir, our president-elect Neela Mohan madam, our president 2024, Dr. Basuraj sir, our HSG Yogesh Parekh sir, our treasurer Atanu Batra sir, our chief advisor Jagdish Shinnappa sir, our national coordinator Priya ma'am, our chairperson for today's program Nandini ma'am, our chief guest Professor Baldev Prajapati sir, and guest of honor Professor C. Kamraj sir, and our esteemed Professor Singaralu sir, our academic team, the wonderful team led by Professor Rajkumar, Professor Murugesa Lakshmanan, Professor Rama Subramaniam, and the young IAP brigades, Moinuddin and Kartiban, and the entire team of Madurai IAP who made us sleepless on a wonderful Thursday afternoon. And you literally drenched us with knowledge and facts on dengue, asthma, AAS, and nephrotic syndrome. I thank all the EB members of our Central IIP and office bearers and and executive members of state branches of our IIP and all the past office bearers of Central IIP and state IIPs. I thank Professor Pramod Jok for the awesome sum up of the events which happened for the past 2 hours. And I also thank the technical team of Central IIP for the excellent broadcast over Zoom as well as the YouTube platform. And I wish you all a wonderful weekend. Catch you all in the second episode, which is going to happen on the third Friday of February 2025. Have a wonderful evening. Thank you, one and
Thank
all.
you. Yeah, just a reminder,
you.
the next session will be on 21st February. That comes on Friday at 2:30 p.m. We are having MIMS Aster Calicut. So I request all of you to join in that time. Thank you. Thank you so much.
Special appreciation to Nandini ma'am. Madam, special
you.
appreciation to Nandini ma'am and
Yes.
Kamraj sir.
I was about to call you, sir.
Fantastic,
Without
fantastic.
your intervention, I think we couldn't have had this Madurai Medical College as a participant today. Thank you. Thank you so much, Singaravel.
Thank you all.
Thank you,
very much.
Baldev sir. Thank you, Kamraj sir. Thank you so much.
Singarvelu
Thank you,
sir
sir.
was our pioneer in the whole central IP program last year. And this year also he is a very enthusiastically participating in the and supporting all the program.
Thank
So,
you.
sir, thank you for this best choice for the Madurai Medical College, you and Kamraj sir as a guest of honor.
Thank you. Thanks,
Thank
Ashwin, for all the technical support. Thank you all.
Bye-bye.
Thank you, Dr.
Thanks,
Amarnath.
Thank you, sir.
Thank you.
Thank you, Amal. See you, MSI.
Yes, sir.
Thank you.
Thank you, sir.
Bye-bye.
Thank you, sir.
Ashwin, you can wind up the session.